What is up? What is up, everybody? Welcome to another episode of the Insomniacs Livestream. I am your host, Dr. Andrew Kim, MD. I'm a board certified psychiatrist. Thank you for hanging in there. Sorry for the slightly late start tonight, guys. Been a long day of work, but I appreciate those who are joining today. And for those of you who are brand new, this is the live stream segment of my YouTube channel, and we do this every Tuesday night and every Saturday night at 10:30 p.m. Central, 11:30 p.m. Eastern. And we do various topics, rather than kind of the normal evergreen videos that I do on various psychiatric and mental health topics. We do some pop psychology. We talk about some current affairs. We do some Q&A sometimes. We do go over random topics. Last episode, we went over outpatient strategies for helping maintain sobriety from alcohol use issues, maybe harm reduction. We also talked about the concept of protracted withdrawal syndrome in the context of benzodiazepine withdrawal. So we do all kinds of stuff. So for those of you who are joining today, we have an interesting episode. I want to kind of do a broad overview. Ray, what's up, Ray? Ray's a regular listener. Fish oil, yeah, omega-3 fatty acids. Yeah, thank you for watching that video. So we talked about omega-3 fatty acids for depression in one of my recent evergreen videos. A rather underappreciated, very low risk intervention, in my opinion, for the use off-label, of course, off-label use for clinical depression. Very interesting research, and maybe one of these upcoming episodes, maybe we could do kind of a catch-all episode talking about various non-prescription interventions like that, maybe in the span of one episode. That might be an interesting topic for us to do. Hey, Lisa, thanks for checking in. Lisa from the Northwest. So today we are going to basically just do a broad overview. I don't want to get too in-depth into any one topic. It's really, I want to just highlight just how fascinating, intriguing, maybe scary, the human mind can be. Okay, we always talk about random things. You hear these cliche phrases in society and pop culture about the power of the mind, the power of positive thinking. It's all about mindset. And today, I really want to highlight what's up, James? James says, thanks, Dr. Kim. Off hand I'm glad. Off hand sanitizer. I'm glad, James. I'm glad that you're here and that you're doing well and that you're okay. So I'm glad to hear that. So, talking about just the depths of how far the human mind can go. And I'm going to talk about maybe some topics that are not as well known, but I really just want us to open up our minds and just appreciate the depths at which the human mind can go to influence our behavior, to influence our emotions, our mindset, our thought patterns. It's fascinating. It's scary and fascinating at the same time. So we're going to cover a few topics. We're going to talk a little bit about functional neurological symptom disorder or functional neurological disorder. Some people call it FND. And we're going to focus on a very specific subtype of FND called psychogenic nonelectrical seizures. We're going to talk a little bit about a very interesting and rare condition called pseudocyesis, and how pseudocyesis, the belief that you are pregnant when you're not, has a delineation from delusions of pregnancy. So that's a very interesting topic. There's some controversy there where some people believe that there shouldn't be a distinction between these two things, and this should all be viewed on a delusional spectrum of a delusional disorder. So we'll talk about that. I want to hear what you think. So pseudocyesis may be a term you've never heard before, okay? Going to touch a little bit on delusional disorders and how delusional disorder is actually separate from schizophrenia. Some will argue again that this should be on the spectrum of schizophrenia, but again, a very not often talked about subtype of psychosis called delusional disorder. And I'm going to give you a couple examples and some anecdotes about things I've seen over the years where it's not often that I think people meet criteria for that, but a couple of instances in 14 years where I've seen some of that. And finally, just a little bit, because we could probably do a whole episode on its own about factitious disorder or factitious disorder basically, subjected to oneself, what we used to call Munchausen syndrome, which we don't use that terminology anymore, but factitious disorder inflicted on the self. Okay. And so we're going to talk about a lot of these things. And I'll give you even some examples of cases that I've seen of factitious disorder. Now, I want to preface this by saying today might be filled with several anecdotes and some stories. And obviously, for the sake of confidentiality and privacy, I'm going to alter locations, maybe even, gender, age, certain details, to basically protect confidentiality. Never want to give any kind of identifiers where someone could, associate this with a specific person. So if you are listening to this and you think that this is describing someone or maybe you happen to be one of the thousands of people I've come across, that would be you wanting to make something fit, because I'm just really altering a lot of details. So, it's not going to be talking about anyone that's going to be identifiable. So first, let's talk about this concept of functional neurological symptom disorder. For short, we just call it kind of FND. So this is what used to be called, or classically was called, conversion disorder in the past. But for several reasons, the DSM-5 TR, or text revision, has now called this, functional neurological symptom disorder, and then in parentheses, conversion disorder. Okay, and this is classified as a somatic symptom and related disorder, somatic disorder subtype. I'm going to be brief here. Basically, the new kind of definition of functional neurological symptom disorder is that in order to have the diagnosis of functional neurologic symptom disorder, it requires each of the following criteria. I'll be quick here. One or more symptoms of altered voluntary motor or sensory function, clinical findings that demonstrate incompatibility between the symptom and recognized neurologic or general medical conditions. The symptom or deficit is not, keywords, is not better explained by another known medical or mental disorder, and the symptom or deficit causes significant distress, psychosocial impairment, or warrants medical evaluation. Okay. And here they give a quick example. We're not going to talk about this subtype. The diagnosis rests upon positive clinical findings that indicate the symptom is inconsistent at different times. For example, quote, a paralyzed limb will move inadvertently when the patient is distracted by performing movements in their unaffected limb. Okay. Now, there are different subtypes. There are subtypes of paralysis, motor function loss, sensory loss, saying I'm numb in certain areas, but we're going to talk about the most common subtype. The most common subtype of FND is going to be something called, and I hate this acronym, it just maybe my mind is in the gutter, but the acronym is PNES, and it's a little too close to something else, but so whoever invented it probably should have thought through the first letter of each of those, in what kind of acronym it makes up, but that stands for Psychogenic Nonelectrical Seizures, PNES. And this is a subtype or one of the manifestations or variations of FND. Okay. And this is where an individual is having episodes that look just like a seizure, and it could be of various subtypes, but for the sake of simplicity, we're going to talk about the subtype where someone falls to the ground, has convulsions, and it looks just like a classic grand mal seizure. Okay. Yes, KG, non-electrical equals non-epileptic. Essentially, a seizure-like event that actually has no objective evidence. If you were hooked up to what is called a EEG, where you put all these sticky leads on your skull or your scalp, and if you happen to catch someone having one of these episodes that looks like a grand mal seizure, you would actually not see the classic electrical activity that you would see in epilepsy. And yes, James, those are different from alcohol withdrawal seizures, because alcohol withdrawal seizures will have electrical activity just like someone who is going through epilepsy. So in this case, that is why they use that term non-electrical seizure, is that These events are not actually electrically driven. Okay, if you were hooked up to an EEG, there's no evidence that this is consistent with epilepsy, which is interesting. Ray asked a very good question, faking it. So that's the important thing. No. And you segued perfectly, perfect timing, Ray, into the next topic of the next important point of this topic is this is not felt to be something that is purposeful feigning, faking of these symptoms. And that's where there does need to be understanding and some sympathy and empathy, is that this is not a condition where someone is purposely, consciously, volitionally doing this. That is the fascinating part. Okay. We could spend forever talking about theories. The theories are loose. As much as everyone would like to nail down a root cause, all of us want to play, including myself, armchair Freud and say, oh, this must be because of trauma. This must be from the trauma of an assault. This must be from a huge outlier stressor. This is from a pending divorce, et cetera, et cetera. Yes, there are some cases where we can identify a psychological root cause causality, but there are many times we can't. And even with I'll say it, with my own frustration, where I've tried over and over and over again, there must be a cause, there must be a cause. Sometimes after numerous sessions over multiple months, as much as we would like to identify a root cause with a psychological factor, sometimes we can't. And that could be frustrating for the patient, frustrating for a clinician. But here's the thing. This is part of the reason why in the description today, I kind of mentioned, well, why have we kind of changed some of the terminology? I think there's a couple reasons. I think one of them was kind of a research-based reason, which I think is very valid, is that we used to say, for conversion disorder or, for psychogenic nonelectrical seizures, there used to be, more of this kind of notion and requirement that it must be, something that we can identify as psychological causality. And we would also have to rule out that someone was quote unquote feigning it, right? Or faking it, right? And how does one do that, right? You're not going to be in the mind of a person, right? And try to understand their motives and their subconscious, unconscious desires. So, because that's just so hard to prove or disprove, that was kind of removed. And because there were definitely cases where, as much as we'd like to identify psychological causality, can't always do that. So rather than using all of these exclusionary criteria, basically just said, look, if you have what seems to be, some, neuromuscular, neurological condition that can't be explained, somewhat off and inconsistent with classic diagnoses, it's more about the presence of these things and these inconsistencies that allow us to now just say, look, you meet criteria for FND, versus saying we have to rule out these amorphous concepts. Okay. So Lisa chimes in, as a pediatric RN or nurse, I saw this with a 10-year-old girl as a school nurse. It looks and acts the same as a seizure disorder. This child saw a traumatic event that resulted in the death of a family member. So yeah, absolutely. And that's the thing, Lisa. So there are still going to be, just to your point, that's a perfect example. There are definitely going to be examples within psychogenic nonelectrical seizures that are going to have an identifiable root cause. And then with the appropriate therapy, with appropriate progress in therapy, that in itself can literally lead to resolution of this condition. Other times it won't be as straightforward and as black and white with cause and effect like that. And I think that's part of the reason that they, kind of remove some of these criteria. I do believe another reason they've changed the terminology is just, I think there is a kind of a pejorative, judgmental, connotation to conversion disorder itself, right? So I think neurologists were probably more akin to using the term FND before psychiatrists as a more acceptable term. And we've just kind of followed in suit at this point. Now, does it cause confusion? Yeah, because now you hear these interchangeable terms: conversion disorder, PNES, functional seizures, FND. I mean, and it gets rather confusing. So honestly, part of me wishes we just kind of kept it the way it was, but I also understand and appreciate the rationale for switching it because yes, I do believe that there is kind of this stigmatized pejorative connotation to what we used to kind of conceptualize it as. Now, last few points here. How does one, go about trying to diagnose this when someone presents with seizure-like activity that just seems very inconsistent? Obviously, comprehensive interview, talking to other sources, looking at the onset of symptoms, right? Because it would be rather odd for, epilepsy to, set on with no particular reason suddenly in the middle of adulthood. But fascinatingly, many patients, who present with PNES, oftentimes, not always, this is just a relatively loose statement, will have an onset, later in their adulthood, like in their 30s, right? So to not have epilepsy growing up as a child, as a teenager, to then suddenly present with this, that's already somewhat of a warning sign. And then let me put up a graphic here with some, again, these are not definitive, but if you look on the left-hand column, they will give you some, again, this is not foolproof, so I don't want anyone to misinterpret. These are not foolproof methodologies to say, but these would just be hints. That's the best way to hints of, trying to say maybe there's enough kind of, red flags to say this is not typical for generalized tonic-clonic epileptic seizures, the typical seizures that most of the lay public are familiar with when someone drops suddenly, goes unconscious, and convulses on the ground. And you could see, we won't read the whole thing line by line, but there are subtle clues. Like in a generalized tonic-clonic seizure, eyes might be open or half open. In PNES, usually they're shut and shut pretty tightly. There's typically, in terms of vocalization of distress, oftentimes there are no emotional features. Oftentimes they're rather inarticulate once the seizure starts happening. In convulsive PNES, patients can clearly vocalize their distress, oftentimes give you a lot of minutia about details sometimes. In what's called a post-ictal state, right after the seizure event ends, oftentimes in generalized tonic-clonic seizures, there's drowsiness, confusion, sleepiness, severe headaches. And in PNES, alertness returns rather quickly. But there tends to be kind of this distress, dysphoria, panic, anxiety, panic attacks, etc. So you can go on and on and on, and there are numerous hints, again, keywords, hints that might cue someone in to say, hey, there are some interesting inconsistencies here. Now, here's the thing. Last comment, then we'll talk about how you go about trying to diagnose this, kind of the gold standard way. Now, interestingly here, what we have to be careful of is patients who have epilepsy, like actual epilepsy, electrically driven seizures, interestingly enough, they have the potential to have intermixed with their actual electrical seizures PNES events, which makes it quite complicated. So just because one has maybe an episode of, a seizure event identified as PNES, you can't also assume that their other events are not electrical in nature, which makes things very complicated. Again, we can go into theories about that because, stress itself can be a risk factor to trigger an electrical seizure in epilepsy, but there may be a tendency of condition patterning where stress itself may induce a psychological event where someone with epilepsy might actually have a PNES event, not to make this crazy and murky. But so we have to be careful. So we have to approach these things very seriously because at the end of the day, it's serious. It's serious whether you have electrical seizures and you need to be on anti-epileptic medication, or we find out it is PNES, but it doesn't change the fact that this is super disruptive and this is super distressing, as Lisa put it, right? I'm sure for that 10-year-old girl, it didn't matter to the 10-year-old girl whether it was epilepsy or not. It was distressing and it was disruptive. And I have to believe that that was that interfered quite a bit with that person's day-to-day life and their schooling, etc. Ray asked multiple personality. Multiple personality, that's an interesting topic. We should probably do a whole segment on that. But one can say that patients who have a history of trauma, that might be seen as a loose risk factor. Patients who have a history of dissociation, which is, what multiple personality is thought to be under the umbrella of dissociative disorders, that could be a risk factor. Patients who have borderline personality disorder, that could be a risk factor. But again, none of these are definitive cause and effect. But to your question, multiple personality, patients who have dissociative tendencies, that could be a risk factor to be at higher risk of developing episodes of PNES. Now, so how does one diagnose this? So if possible, the goal would be to plan out getting an EEG, an electroencephalogram. You put these sticky leads and electrodes on your scalp to capture electrical seizure events. And the goal would be, could you capture several of these events while under monitoring? The gold standard, and I'm going to be straight here, the gold standard is not always possible, but the gold standard would be to have someone go into a supervised hospital setting, to be set up for an EEG, and to also have video monitoring so that you're capturing this on the electrodes, actually seeing the electrical events, and then correlating to what you see on video. Okay. And ideally, you'd like to capture this and monitor them for at least 48 hours. And I know that's not always so easy, because imagine the hospital bill for a 48-hour stay, right? And if you don't have good insurance, that's what makes this so difficult. So sometimes people will do this on an outpatient basis. It's just tougher because you're not probably going to have that video element. But at the very least, you'll capture the episodes, and you can have the remote EEG at least transmit some of the data to hopefully see if these are electrical or not. Not as good in my opinion, but ideally you'd like to be in a hospital setting or a supervised setting for 48 hours. And the reason I say 48 is that statistically speaking, you can catch the bulk of these typically within that period. Again, loose statement, but that's typically what we see. All right. And now, if you capture several of these events, the events that the patient and the family members and loved ones say are the typical events that happen, you don't see classic electrical activity that is consistent with a seizure, then you have much more definitive proof that this, in fact, is PNES. Now, here's the interesting thing, right? Here's the interesting thing. I can't give you exact numbers, but there is a portion of patients coming to the realization and having much more concrete proof that this is not electrical epilepsy in itself ends up being curative. So those are some patients where you're almost addressing some psychological concern, maybe anxiety about somatic symptoms and illness and having epilepsy, that you have provided some level of psychological relief and clarity and lucidity that this is not epilepsy. Interestingly, a small percentage of patients, and the stats rate vary quite broadly. Some studies will say 10%, others will say 20%, but that in itself can lead to remission of this and resolution. That's fascinating. And I have seen that happen, that once we've said, oh, this is not electrical, we're not trying to diminish the distress you're going through, but good news. And that's how you should, good news. This is not epilepsy. You will not need to be on anti-epileptic or seizure meds for the rest of your life. That in itself sometimes is actually therapeutic and even curative. Fascinating phenomenon. Okay. Now, for others, it won't be that simple. And then it becomes quite complicated, right? Because again, for those that you can, just to Lisa's point, for those that you can identify a hypothesized psychological root cause or at least contributing factor, for those, therapy itself may be the road to go. And therapy can, lead to resolution and remission of this. Other times, you may have to see what other comorbidities are there. Is there maybe a different comorbid psychiatric issue that is the actual root cause? Is this from depression? Is this from anxiety? Is this from PTSD? Is this from borderline personality disorder? And you have to address that with the standard fare, algorithms of treatment. And it gets very murky when you can't identify um, a root comorbid diagnosis, a root psychological cause. And in those cases, oftentimes it becomes about reassurance, making sure all the other known medical conditions are treated, and really almost kind of a therapy, I would say almost akin to acceptance and commitment therapy, saying almost like someone who is living with chronic pain, that we may have to accept that right now, at least right now, and that may change, we can't identify a root causality. We want to validate and say that this is disruptive, this is distressing, but how do we help you find meaning to live a meaningful life and still live your life, work on your goals, even though it may get disrupted from time to time with these kind of episodes? And I know that may not sound satisfactory, but sometimes that's where you may need to start, to be supportive, to be validating, but also focus on reaching goals and still trying to live your day-to-day life in a meaningful way. And that may just be a starting point, but sometimes that's where you may need to start. So again, very interesting phenomenon. Very interesting phenomenon. So let's move on to whet your appetite with that. Let's talk about probably something that is not as well known as that, because some of you may have, like Lisa, some of you may have come across PNES before. You may have seen it, you may know someone with it. Let's talk about pseudocyesis. And let's distinguish pseudocyesis from delusional pregnancy or delusions of pregnancy. Okay. So this is probably the simplest way I can put it. There is some controversy that these things should not necessarily be seen as different things. And I think that's a very fair argument, because I have seen probably two cases in 14 years of pseudocyesis, or at least what looked to be as close to pseudocyesis as one can see. But this is the most simplistic way I can kind of say it. A distinction has been drawn between pseudocyesis, and this is the key phrase here, where signs of pregnancy are demonstrably present, meaning there are overt physical clues or hints that maybe one might be pregnant. Abdominal distension or abdominal swelling, maybe their menstrual cycle has been off or has actually stopped. Spotting is happening. There's actually breast enlargement. Weight gain is happening. There's actually breast milk production. Versus delusions of pregnancy, where yes, maybe there is a change in menstrual cycle, maybe there's a little bit of abdominal distension, but otherwise no other overt signs like what I have listed, but there is a fixed false belief, a la delusions. That's why they call it delusions of pregnancy, which is viewed as a psychotic disorder, but they're actually distinguishing these two things. Okay, where they view pseudocyesis as a somatoform disorder, while the latter, delusions of pregnancy, is just viewed as something on the spectrum of psychosis and a psychotic disorder. Okay, so last thing here, and then I'll give you an example of a case that I ran across. So for pseudocyesis, the clinical presentation has both psychological and physiological aspects. Affected women are not pregnant, but maintain a belief that they are pregnant even after pregnancy has been ruled out. Women with pseudocyesis may also have one or more of the following signs or symptoms. And I read some of these, so I'm not going to read through them, but like abdominal enlargement, menstrual changes. They feel that there is a sensation of fetal movement, GI issues, etc. Okay, so, but again, there are these physical signs, and it's some of these physical signs that may be contributing to this belief. Okay, so let me give you an actual anecdote, right? And again, some details were changed. Locations, I'm going to report random locations, but let's say in Texas, at a particular hospital that I was working at in the emergency room, a couple came in to the ER. I was asked to consult as a consulting psychiatrist in the ER for an emergency consultation. I said, "What's going on?" And they said, a couple came in, and the lady, we had an urgent OBGYN consult because they came in. They said, the man said, "My wife is on the verge of delivering." And the man came in with, what do you call it? A baby carrier, an empty one, saying, "I'm even ready. I got everything. I got a baby carrier ready. Just so after delivery, we're ready to go home. Look how responsible I am. I have all this like baby gear, baby equipment. We got our diapers. I'm ready to go." Just like revved up, half freaked out, half excited. So apparently before I arrived, they did an OB consultation. They did all the standard fare workup because this was someone that was not known in their system right now, seeing someone at that hospital. So kind of a random, urgent, visit to the ER. And, they brought me to the side and said, I'm like, "Is this for postpartum depression or peripartum depression? What's going on? High risk pregnancy?" And they said, "No, Dr. Kim." They're like, "This woman is not pregnant. We ran a pregnancy test. We did an ultrasound. Nothing, nothing, nothing. They won't believe us." Going back to that criteria, I said, report, even with evidence presented that one is not pregnant, still believing it. Right? So I went in, talked, gathered info, and they said, "Oh yeah, look, they even, the tech even showed the ultrasound saying there's nothing there." Interestingly, the patient said, "No, look, that little, fuzzy white noise in the background, like, oh, that's the hand." Gave me a very long-winded narrative of how the pregnancy has progressed, all the things that they've done to eat healthy, to try not to gain too much weight. They've been taking the, prenatal vitamins, and the husband was going on and on about how thrilled they are and how the family's all on standby. And it was a challenging conversation, right? To state that, look, to the contrary. And how do you navigate that conversation? It's challenging, right? On one hand, you're ready to hear a letdown, some anger, some disbelief, some argumentative nature. But also, it's important to be truthful, right? And be direct and say, right now, like, you are not pregnant. It was a challenging conversation. And interestingly enough, it was hard to identify anything else, meaning, as much as I wanted to interview, talk to the husband, talk to others, there was no reports of observed hallucinatory experiences. There was no past history of schizophrenia. The mother had been, working at a job until they were on leave for maternity leave. So they even went on maternity leave for this. It didn't seem like there was ulterior motive for like secondary gain to just, be on leave and take a vacation, right? So it didn't seem like there was some like malingering happening. And we had to break the news to them. And then the craziest part was, and I'm not making fun of this because this is actually sometimes, I would say, rare. So number one, this is rare in itself. But this is also another rare thing that can happen, and there's actually literature on this, that the husband, after we broke the news, kind of went MIA and just kind of started saying, "No, we're going to be getting ready to take the baby home," and then vanished. And then, because of not knowing what was going on, where the husband went, and because of just how convicted both were in this phenomenon, the hospital had to start a code pink, worrying that this gentleman was headed to the nursery to maybe just take a baby to fulfill the idea that they were going home with a baby. And eventually they were found. I think because of the nature of this incident and the fact that we didn't feel that they were there with malicious intent to just want to kidnap babies, but eventually some insight was gained over the next few days while they were in the hospital that luckily it didn't have to go into the legal domain. But I mean, that's the level of conviction, and you can go read case literature It's in the public domain, and type in pseudocyesis and kidnappings or baby nappings and see what you find. And you will actually find literature that this condition has been linked to, not a ton, I mean, it's a rare condition, but there have been some cases where it has led to people trying to even kidnap, not babies in the hospital even, but like kidnap other children. And rare, so I don't want to oversell that part to, cause sensationalism, but I'm just saying, like, I've seen it myself with my own eyes where panic ensued in the context of this interesting phenomenon. So I mean, I don't know. Like, I'm gonna say, like, because there is still to this day controversy that, are we arbitrarily putting this in a somatoform disorder category because we don't want to be judgmental and pejorative and stigmatizing versus just calling this a delusional disorder. So it's somewhat of a, rather, in my opinion, a little bit of an arbitrary distinction saying delusions of pregnancy when there's not as many overt signs is a delusional disorder or psychotic disorder, and when there are overt signs, um, but still a conviction in a pregnancy that does not exist even when evidence is presented, that we're not calling this a delusional disorder, we're calling this a bodily somatoform disorder. I don't know. That's because when I was in that position, and even my supervisors and others, we felt, hey, this is likely the closest thing we've seen to this subtype of pseudocyesis. I mean, the level of conviction was, in my opinion, delusional. Okay. So when we look at the theories, like, how does this differ, like, theoretically, how does this even evolve to the point where we're not saying this is schizophrenia or a psychotic disorder, but how does one get to the point where there is this level of conviction? So there are some theories of somatic psychic causalities, meaning when one is having these bodily changes for whatever reason, right? Let's say there is actually a hormonal problem, too much prolactin is being released for some reason, and that's leading to breast enlargement, milk production, cessation of your period, right? Um, for example, let's say you don't have schizophrenia, but you're taking an antipsychotic for augmenting your antidepressant as, kind of a second step for someone who didn't respond to an SSRI. Even if you're taking a low dose, antipsychotics can increase prolactin. It's that's a known thing. That's why you see those commercials late at night. Sometimes, if people even watch TV anymore, saying, has your son, has your loved one, a male in your family, taken risperidone, and have they developed breast tissue called gynecomastia? Call us now so we could sue the hell out of everyone, right? It's a known thing, right? For men, it's called gynecomastia, like men develop breast tissue sometimes as a very unfortunate unintended consequence of antipsychotic exposure. But women, because they already have breast tissue, might have breast enlargement, breast milk production, and increased prolactin can stop your menstrual cycles and you can get amenorrhea, or at least irregular cycles, right? So I know that's a very specific type, but I'm just giving you an example where maybe there is a known cause of altering those things that could at least show you hints that one is pregnant. And then from there, does that feed into a belief system, right? That one is pregnant. Maybe there is psychosocial pressure that you're supposed to be having a child. Look at your, hey, you're getting too old. Like, you got to have a child soon. Maybe there's expectations of friends and family members, sisters who are having babies and you haven't had one yet. That pressure. Maybe it's a very, big desire and fantasy to have a child, start a family, right? So maybe there has been some link and studies about trauma and loss being a psychological cause. So if we don't want to go from bodily change to reinforcing belief, the other is, again, psychological causalities. And there has been some literature about trauma, loss, death of loved ones, loss of a previous pregnancy that can then trigger this convicted belief in that one is pregnant when they see these subtle signs, right? So we can go on, but there are numerous theories, and they go both directions, like noticing the bodily changes to then reinforce beliefs. Some view this as an extreme version of denial. When you want to be pregnant so badly, this is extreme denial. And so these are some of the reasons that folks are saying that this is distinct from a classic psychotic disorder, where this is psychosis and delusions are the primary symptoms. They're saying this is in the somatoform family of disorders because there are bodily changes that then may be the gasoline to the fire of this conviction. But man, in the few cases, like I said, the couple cases I've seen in 14 years, that conviction is so fixed and quite delusional, in my opinion, that I really can't. I almost feel like it's like a real esoteric debate to make an arbitrary line of where does delusional disorders end and where does this begin as pseudocyesis. So again, I have seen it myself. It is a rare thing. It's controversial whether it should be distinct from a delusional disorder or not. But that's what pseudocyesis is. But it's just to illustrate, again, the concept of today's talk, the power of the mind. So Ray says, is extreme delusion a break with reality? Yes, I would say, I know it's somewhat of a general commentary, but we consider delusions to be a fixed, keyword fixed false belief is something that doesn't really have evidence or is based in reality. So yes, there is a component of having a break from reality. So that's why it's on that fringe, right? I just said, I flashed that criteria up earlier saying, even when presented with evidence that one is not pregnant, they still believe it. So how in that's, right? Like if we really want to get into the nitty gritty, it's like, well, then by the nature of that is delusional, right? So I think the argument that some are making is that that is not the primary component, of this syndrome, that like maybe, yes, it may be a symptom, but not the primary core feature that we should now just categorize this as a somatoform disorder. But man, when you see it, it's something else. I mean, the level of conviction in that case that I'm referring to, it was the real deal. Imagine that, right? And there's other terminology for when people around you are then drawn into this convicted belief. Because I said it wasn't just the woman, it was the wife, it was the husband who also said, I've been getting ready. They bought all the stuff, ready to go. He was all in. The family was all in. Family members were there waiting for the delivery. So family members were in, husband was in. I mean, it went beyond the actual patient herself. It was a fascinating situation. And then the cherry on top was the panic that ensued. So let's talk, though. This segues the last two topics we'll talk about, just to kind of, again, illustrate the spectrum of what the mind can do as a human being. Is let's talk about delusional disorders. Let's cross into that realm. So rather than this, is pseudocyesis delusional or not, let's just talk about delusional disorders. Okay. And again, we talked, if you were here, was it 2-3 episodes ago? We talked about schizophrenia and the ins and outs of that. This is distinct from schizophrenia. So again, this is why I'm saying it's not as commonly talked about. And I wanted to at least throw this in there, kind of in the spectrum of what the mind can do for today's talk. So delusional disorder, I'm going to put it up here for those of you who really want the nitty gritty of the DSM. So the diagnosis of delusional disorder, right? It requires the presence of one or more delusions with a duration of 1 month or longer. Here's the thing. Criterion A for schizophrenia has never been met. But they do make an allowance. You can have hallucinations, but if you have hallucinations, they're not prominent, and they need to be related to the delusional theme. They can't be random hallucinations about other themes that are not part of your delusional network. So for example, the example they give you is the example of, and this is the one we'll probably talk about, is a classic theme we find in delusional disorder called delusional parasitosis. you have the delusion that you are infested. Your body is infested with parasites or insects. And so one can say, I feel them under my skin. I can hear them chirping and their wings fluttering. So whether it's auditory or tactile, but because it is related to that theme, we're saying, that in itself is not enough to say this is schizophrenia. And this is more of a delusional part of the construct of delusional disorder. Now, here's the key, because one will say, well, that's very, esoteric and arbitrary, but criterion C for this is apart from the impact of the delusion or its ramifications, functioning is not markedly impaired and behavior is not obviously bizarre or odd. And I know that's, again, an arbitrary distinction, but if one could compartmentalize the delusions in that person's life about that one theme or one or two themes, one might actually have a challenge saying there's something wrong with this individual. The rest of their life, the other domains and the other aspects of their life might be okay. And one could not even detect from the outside looking in that there was anything wrong. And I will say that is different than, I would say, your classic common case of schizophrenia. And there are subtypes of delusional disorder. There are the romantic subtypes, erotic romantic delusions that, you are married to this particular person or that there's some affair going on when there isn't. You have delusional disorder about jealousy, that someone is cheating on you and there's infidelity and there's just a convicted belief in it, even if it's actually not happening. And it is extreme. It is not anxiety. I mean, there is a elaborate convicted delusional network about this. There are grandiose subtypes. Probably the most well-known are the paranoid subtypes, that there's a conspiracy against you, that you're being followed. But for our anecdote for this example, before we move on to factitious disorder, I will give you an anecdote of delusional parasitosis or delusions of infestation. Again, this was a long time ago, back in the day when I was actually in an emergency room setting and had someone come in. This gentleman was a firefighter. Again, I'm changing up details, but gentleman who was a firefighter. Family brought him in saying, we don't know what to do anymore. We're at our wit's end. And I was consulted because they were saying, hey, we're concerned that this gentleman is having, some type of break from reality. They are convinced that they are infested with parasites. And this fireman said, man, it's the damnedest thing, Dr. Kim. I've been trying to catch one of these. I've been taking samples to my primary care doctor. I've been taking samples to the dermatologist. And these things are so tricky that even when I bring them these dead samples, they can't seem to identify what it is. And then I looked at the family. I asked them, what are these samples that he's bringing? And to me, again, privately, they're saying, look, and they even showed me an example. And they said, here's a Ziploc bag of the samples. And essentially they were, flakes of dry skin, okay, or scabs. And they say he is convinced that, these are the discarded shells, or coverings of these parasites or these insects that have infested him. And he'll just collect these samples, which end up being skin cells. And they said, even one of the, dermatologists and specialists wanted to try to understand what was going on and sent them off and got the path report, and they're just skin cells essentially, right? But he continues to collect these samples. And then speaking with him and the family, the fireman said, look, I'm a fireman. I know what fire can do and what kind of damage it does. So they say that they have caught him repeatedly at night, taking one of those extendable lighters that you see in the kitchen, right? Those extension lighters. Luckily, thankfully, not burning his skin, but hovering the lighter above his forearm, above his thigh, above right in front of his chest and sternum. And they're like, what are you doing? What are you doing, sweetheart? Like, you're going to burn yourself. Be careful. I'm a firefighter. I know what I'm doing. And he's saying, this is the only way to like sterilize, right? And try to kill the eggs and the larva and the etc. to kind of keep this in check and to keep this at bay. Saying, because right now the dermatologist, the primary care doctor keep telling me there's nothing wrong. So until I can get a viable sample to identify exactly what parasite this is, because they keep saying it's just dried skin cell, they don't believe me, I'm going to have to keep this thing under control, right? And he had all these elaborate theories about why heat was an effective treatment. He had theories about what it might be. Interestingly, right, when I interviewed the family very elaborately, the kids who were there, the spouse said, he is one of the most respected firemen at the firehouse. He has all these, exemplary medals of honors for, service, honored by the community, by the park district, by the county, et cetera, et cetera. He's been heralded as like, an amazing trainer for the trainee firemen, et cetera, saying he has no problems at work. None. Been promoted. He's a supervisor. He's a wonderful father, wonderful husband. He's a coach for Park District basketball. He is the breadwinner. But in this one domain, think about the level of conviction that I just conveyed, about the level of systematized detail about being infested, having this larva, even when told by doctors, this is nothing that you're saying, hey, maybe you should go see a psychiatrist. Total conviction. If you bring up this topic, it opened a floodgate. When I asked him just to see what would happen, said, well, how about them Dallas Mavericks? How about them Dallas Cowboys? How was it when you saw your son's football varsity game on Friday night? Oh, it's almost like I'm just shooting the wind with a random guy, just talking about, sharing stories about families, this and that. So that's the closest thing, right? I mean, that's one of the few times in 14 years, I've probably just had a few cases where I'm like, I'm stumped. This is not your classic schizophrenia, yet it is a pretty convicted, all-in, detailed, elaborate, systematized delusional network, but just kind of in this one area. And somehow, I don't know how, I'm not saying there was no distress. Of course, it's causing distress. It's causing distress to him emotionally, causing distress to the family. It's preoccupying the family when this topic comes up. Obviously, you don't want him doing something more extreme than taking a extension lighter and waving it on this a few inches above his skin, right? So, of course, I'm not diminishing. I'm not saying there isn't impact, but I'm saying, interestingly enough, in a very compartmentalized way, functioning in all these other domains, right? So it really kind of fits the criteria that I flashed up earlier. Maybe there is this subtype of delusional disorder, right? Fascinating stuff how the human mind works. So again, very tricky because insight into the delusional framework is so limited that attempts to try to say, hey, we need you to do therapy is often met with resistance. Saying, hey, I'd like to give you an antipsychotic, which honestly doesn't even really have evidence of being that great for delusional disorder, because like I mentioned in my other video, antipsychotics tend to be better for hallucinatory symptoms, not so much for delusions, unfortunately. I mean, there's some evidence could modestly help at best, but try to engage someone to say, hey, essentially you're conveying, I don't believe you, even if you don't use those words. That's what's going to be interpreted half the time, most of the time. That's a tough sell. It's often going to be met with suspicion or will be interpreted as you don't believe me. So there needs to be a lot of alliance building before you can even attempt something that might actually get you mixed results. So it is also a tough cookie, a tough diagnosis to address and treat. Very challenging, very challenging. So finally, Ray says gender identity might have fallen into this. Oh yeah, I mean gender identity issues, gender dysphoria, I mean, was back in the day, kind of categorized as pathology. Obviously, that's not the case anymore. Still an area of controversy. So that in itself, right? We can go into a whole topic on that at some point, which probably get me canceled at some point. But I mean, it's such a contentious topic that most people don't even want to broach it. Finally, let's segue into the realm of factitious disorder. And we're going to do this very briefly for the sake of time because we're already up at about an hour here. Because I think this is so fascinating. If there's enough interest, one day we could probably do a whole episode on what used to be called Munchausen syndrome, now just called factitious disorder. Factitious disorder inflicted on the self. Okay. So this is interesting, right? So something that does need to be there for factitious disorder is an element or a feature of deception. Okay. While deceptive behavior itself is not necessarily pathological, it's the persistent nature of factitious behaviors that can lead to a lot of problems in these people's lives, right? And patients may feign, and this is to go back to, was it I believe it was Ray, or, was it Ray? Yeah, Ray asked the question, faking it. This is where that is applicable, Ray. So patients may feign symptoms and feign illness by either exaggerating or fabricating their symptoms or medical history, exacerbating or actually causing and inducing signs, physiological disturbances, causing illness. You can literally inject, they give examples here, injecting yourself with blood thinners, injecting yourself with insulin to drop your blood sugars, taking laxatives to cause GI issues. Literally, you think it's absurd, but trust me, I have seen it. We have caught patients in the hospital doing this, literally contaminating their urine samples by putting dirty stuff in their urine, rubbing poop into their urine. And then we realize when we get the urinalysis, oh yeah, this is a contaminated sample. You think I'm telling you, today's episode, we're talking about the depths that the human mind and human nature can go. Okay. Biting the inner part of their mouth, making themselves bleed to then spit up blood, saying they're coughing up blood. Putting hot things on themselves to say they have a fever. They might actually have actual medical conditions, but finding ways to exacerbate them purposely. I talked about PNES earlier, right? I said that is not someone who is malingering or purposely trying to do it, but let's say someone has epilepsy and they're purposely triggering seizures by maybe stressing themselves out or knowing certain triggers while not taking their anti-epileptic medicine, and they're purposely exacerbating it. Forging their medical record. I'm not kidding you. People go as far as forging their medical records. Coaching their loved ones. I have witnessed this. Almost brainwashing, coercing, threatening, forcing their loved ones, their spouses, their boyfriends, their girlfriends, their wives, their husbands to fabricate and say things to support their fabrication. Okay? So this is a very different beast than some of the other things we talked about today. Let's see if I can widen this for you here. I'm not going to read all these. Like we talked about methods that people are, the lengths that people are going to. Right. Look at, I mean, the most easy one to be relatable. We've all, come on, as a student at one point, did you try to get out of school by trying to raise your temperature on a thermometer, right? But like, look at that last row, trying to feign a fever. James, yeah, man, you should go get some help, my friend. Okay, whether that's getting checked out at the ER, going voluntarily to a detox, you got to get help, James. Okay. And the fact that you're asking tells me you got that healthy side of your ambivalence. Whatever you can do to raise that voice and just roll with that motivation, even though you're frustrated that it seems to be a cycle that keeps happening over and over, it's worth trying again, James, getting some help. So I'll leave it at that. Oh, I know you're not trying to fake anything. I know you're struggling, James. So all I'm saying is I want you to figure out how to motivate and listen to that healthy side of your ambivalence the best you can and try to strike while the iron's hot. That's the key. So going back to the topic here. So fever is a relatable one. Some of these I've never heard. I'm not gonna lie, I haven't heard of some of these. Applying cigarette ash to your underwear to simulate vaginal discharge. That one's new to me. Okay. But yeah, I've seen some self-mutilation literally causing cuts on the vaginal wall. I've seen that. That has happened. So look at this list here. But this is the length. This is the length that people will go to. Okay, to simulate or fabricate illness, signs, etc. Right? So let me see if there's any other ones that, yeah, here's the ones I was talking. See, I wasn't making it up. Like people mimic bacteriuria, basically contaminating. Literally, man, that has happened. There has been a case, I can recall a case where they're literally, trying to get the opening of their urethra dirty, or just trying to, if no one's watching, putting stuff into their urine sample, right? Usually, when people think about it, you're trying to give a clean urine sample for a drug test, but this is the opposite. You're trying to contaminate your urine sample, right? Hematuria, just, you're putting blood in your urine. You're taking blood thinners on purpose so you could try to bring more legitimacy to your bloody urine sample. Man, that's taken it far. Okay. But these are the lengths that people will go to for factitious disorder. Now, here's the thing, right? For factitious disorder, we need to distinguish this from malingering, right? In factitious disorder, we need to delineate, right? This isn't necessarily done for an easy to identify, overt, obvious external reward, right? That this isn't necessarily, I'm doing this so I can get out of work. I'm doing this so I can get on disability, right? That's more akin to malingering. There is this very clear-cut, tangible benefit that one would gain, and that is the goal, to get that benefit, right? To derive some benefit out of this, where with factitious disorder, there is no clear-cut external reward that you're trying to get as the end goal. Some hypothesize it's just being ill itself, or being in the sick role itself, that is a component of what is happening in factitious disorder. Okay. And they're also not exclusive of one another, right? So you can have both elements. There are folks where there is a component of factitious disorder where there is kind of this drive to kind of be sick, be in the sick role, but there are also maybe times where it is also leveraged and manipulated and utilized to get some kind of clear-cut overt gain, right? So, again, right, fascinating about what the mind can do to mimic neurological disorders like psychogenic nonelectrical seizures, what the mind can do and the lines get blurred with pseudocyesis and delusional disorder. And this is a different case where there is some volitional, intentional activities going on to fabricate, feign, and exaggerate wanting to be sick. So I'm going to end with this anecdote. I know this is going to sound extreme. Okay. Again, changing of details, right? This one was a case in the Chicagoland area, right? Is that location real? I don't know. Just changing of details. And there was a lady, female woman, who I got kind of peripherally involved in a case where someone who is doing a third opinion, a neurologist who is doing a third opinion, was getting suspicious about this patient's existing diagnosis of ALS, right? This person was already confined to a motorized wheelchair. This person was utilizing a ventilator, right? So they had a trach here and they were, using a vent for breathing. Their spouse, their husband, seemed very supportive, distraught with the progress of this. Because again, with ALS, right, just worsening paralysis of muscles, leading to premature death. And, again, I was really just kind of peripherally involved in this case. I'd seen a couple of these. It's not common, but I mean, this is how extreme this can get. And, I just learned more details about the case, and they said, well, something just doesn't add up. They're like, every time I ask for records, I'm like the third neurologist. I'm giving like a third opinion here because their primary care doctor is kind of confused. Prognosis was supposed to be patient might have X amount of time left. They far exceeded this. They seem to have, more remaining motor functioning than we would have expected. There were some reports that on physical exams, some findings were inconsistent, raising eyebrows of, noticing some movements that shouldn't be happening. And then this person who was doing like this third opinion said, weirdly, every time I've asked, this lady and the husband for their extensive medical records, which probably should be a stack of medical records with all the years of diagnoses, etc., I always get this smattering, just a smattering of incomplete records. And, they share the records with me. And yeah, it was weird. It was like you would see like page 9 of 20, but then the other, 19 pages were missing. You would see these random pages that say rule out ALS question mark, but never saying like, elaborate paragraph saying like, we believe that this is ALS. We've ruled out X, Y, and Z. And then, and it also seemed like maybe this guy wasn't the third opinion. This might be the 7th or 8th opinion when we actually scrutinize the record. Why is this the 7th neurologist? Or why is there 5 pulmonologists, right? So why like so many different doctors versus just sticking with one renowned specialist in the region or the area, right? So just all these questions were, kind of piling up. And myself and my colleagues on the psych service were like, I'm not gonna lie. We said, there was something about this lady. Also kind of reeked of possible sociopathy, raised some red flags. We ended up doing a battery of psychological testing that scored high on some traits. And again, psychological tests are psychological tests, but, high on features for, possible malingering, inconsistencies, sociopathic traits, etc. And then we shared that, with the guy who was doing the third opinion. And then, what they decided, let's just use this opportunity let's start from scratch. Let's do a little bit of a workup because I got incomplete records. I'm picking up this case mid-treatment. I don't know why I have incomplete histories. They're not giving me releases of information to talk to their prior providers, which is very odd. You'd think they want continuity of care. So they actually ended up doing combination of a pulmonary study. They wanted to see if they needed to change the vent settings, optimize that. There was complaints about sleep problems, so they were going to also just get their bang for their buck and do a sleep study, check their pulmonology results. So they actually had this woman come to a sleep lab to do an overnight observation. And little did they know, or maybe they forgot, there was video monitoring involved. And what do you know? Hallelujah. This lab witnessed a miracle. And when this lady thought no one was looking, got up, walked around, no wheelchair, decided to go grab a cup of coffee that was left over in a coffee pot. Sips on it, relaxed, calm, cool, collected. And when finished, thinking nobody's watching, goes back, lays down, press play, press on pause, and they went back to acting the way that they were acting. Holy crap. Can you imagine, right? So there was some other juicy details, but I don't want to get into it because that might make it a little bit identifiable. But can you imagine the lengths that one would go to sit in a wheelchair for years with an S, to allow yourself to get cut here, to be on a machine that's pumping air in and out, to put your husband and your loved ones through all the mental and emotional stress of supporting you as if you're about to die, and watching you suffer with paralysis, supposedly. Can you imagine that? For those, there's still several of you here. Can you imagine what I am describing right now? Maybe some of you are not shocked. Maybe some of you are like, that's human nature. And that doesn't shock me. But man, I'm just saying, just to the degree that one would go. And that's why I'm sharing that particular anecdote. It's just to the degree that one would go to get some type of subconscious, unconscious, maybe conscious need met. Probably conscious to some degree, actually, but this need met to be ill, to be in the sick role, to be viewed as ill. I mean, I don't even know what to say. I mean, that's something that I will never forget. In addition to never forgetting the couple cases of possible pseudocyesis, the couple cases of delusional parasitosis or delusional disorder that's distinct from that. I will tell you right now, of all these things we've talked about, I probably right now have I kid you not, probably close to 50, 60 cases of PNES right now. So that one's a lot more common than we can imagine. But hopefully, one of these broad topics is something that you've never heard about. One of these is something that maybe you've just heard a buzzword about, but now actually know some fundamental details about. But it's just to illustrate to you the spectrum of what the mind is capable of. The mind is a beautiful thing. The mind is part of the connection to our soul that produces beautiful things, art, poetry, love, faith, creative ideas and projects and manifestations, right, of an extension of our soul. That's what we use our mind for. It's a beautiful thing. It's a constructive thing, but it's also a pretty scary and fascinating thing all at the same time. So this is why, as much as I have become cynical over the years, I've become jaded, and sometimes I do hit burnout when I work as a psychiatrist. I can tell you right now, I rarely have a boring day. Boring is different than tiring and exhausted and stressful, but there's never a boring day in psychiatry. Because if you could step back and appreciate just the breadth of what you get to examine as a psychiatrist and the challenges you have to face and the puzzle, which is the human mind, good Lord, this is part of the reason I went into this field, right? It is just fascinating dealing with humans. Obviously, fascination comes with the need for empathy because of the distress and the suffering that these conditions can cause. But if we approach this with curiosity and a willingness to learn, that's how we be decent to one another, right? To be open-minded, to want to learn, to want to understand, and that's how we make society a better place. Without that, we're lost. So hopefully, this has opened up your minds. You found something interesting here, and we'll end it with 5 minutes because I got energy for 5 minutes for any Q&A. I know that was a random walk down memory lane of random anecdotes of various niche diagnoses. But we'll open it up just for Q&A about any of these topics. Give it a minute or two for any questions for those of you who've hung out. Right now, it's already, good Lord, it's getting close to 1 a.m. on the East Coast. For those of you who are still listening, God bless you. Those of you here in the Midwest, it's almost freaking midnight. You guys got to get to sleep soon. Those of you on the West Coast, I guess the night owls are still just starting their night. But thank you again for joining the Insomniacs Livestream. We do this Tuesday night, Saturday night, 10:30 Central, 11:30 Eastern. See what kind of interesting topic we come up with next. But thank you guys for hanging in there. There's still several of you here on the chat. I appreciate you regular listeners. Psychopathy. Ray says psychopathy would be an interesting topic. Is it understood very well? Yes and no. I think there's definitely room where we could talk about psychopathy versus sociopathy. What I'd like to do probably, if we ever do that topic, to make it more interesting, I really would like to invite a guest, and I'd like to bring in a forensic psychiatrist where this is right up their alley. I know where my limits are, and definitely I don't think I would do that topic justice. So if I can finagle getting one of my former colleagues who's still actively practicing as a forensic psychiatrist, I'm going to see if I can make that happen. And I'd love to have a guest speaker so that even myself, I'd like to throw some questions at them because I do think it's a very fascinating topic. And Ray, you know it is, right? Because how much in our pop culture, how many of our TV shows and series are based off, this concept of sociopathy, psychopathy. I mean, like Dexter, right? All these things. There is a fascination, right? How much of these like true crime shows are, still going on? So if I'm gonna try to finagle. So it sounds like Cole wants to see that happen. Ray wants to see that happen. KG, yes. So I'm gonna try to beg and coerce and bribe one of my colleagues to come on, so maybe we could do kind of and I'll be flexible. If they can't make it this late and they don't want to be a night owl like me, we could probably have to do an impromptu date and time. I would give a lot of lead time for that, so I'll see if I can make it happen in the upcoming months. I'm gonna have to pull some strings and see if I can convince them. I know some of my colleagues are shy about coming on social media. They worry about something being in the ether and being played in perpetuity, being scrutinized. You get a lot of dickheads making nasty comments. I just tell them, just ignore it the best you can. It's just, at this point, I've been doing this long enough. I'm just like, no matter what I do, people are going to hate me. I've even gotten death threats from this YouTube stuff. So it is what it is, man. So they can come in disguise. We should be able to use AI to put some emoji on their face and stuff, or AI that changes their face and puts someone else's face while they're talking, right? So But yeah, we'll try to make that. That's a good. So I appreciate you. I mean, I know you guys gave me the idea for the alcohol use disorder talk, benzo protracted withdrawal talk. So yeah, that would be cool. I think if we can, I don't know when I can make it happen, but I think if we do it, that's how I want to do it. I want to bring in someone who's a real expert on that topic. So, I'm going to definitely put that on my to-do list. See, even if it's not the one colleague that I'm thinking of right now, I'll see if I could finagle one of my colleagues who has at least some forensic background to come in, because that would be fun. That would be fun because I have questions. I have questions because that's not, that's an area I'm not an expert in. Autism's not an area I'm an expert in. So I also know my limits. I'm a very good jack of all trades, and treatment resistant depression, addictions, OCD, anxiety disorders, bipolar disorder, schizophrenia. Those are areas where, yeah, I know quite a lot, but there are also areas where I'm not an expert. I'd love to bring in someone for postpartum depression and peripartum depression at some point too, because I'd love for an expert to come in and talk about that. So, doppelganger for Dr. Julius Ludwig August Coach, founder of the term psychopathy. Pete says, Pete, thanks for joining, Pete. Pete's been here before. Pete, do you think you can talk about the current psychiatry practices in relation to the current government administration? No, Pete. I mean, I'd have to think about that. I mean, it's definitely been on my mind because, I've been getting emails and, vocalizations of concerns from patients and family members of patients of mine saying, what's going to be happening with all the changes at the NIH, is there going to be changes in funding to, Medicaid, what's happening now with the new administration saying there's only two genders, and there's even right now, right, there was an initial, maybe I'm misunderstanding, but an executive order to, not allow gender transition surgeries, for anyone under 19. But then it sounds like a judge from Seattle put some kind of temporary, I don't even know the right term, injunction or pause on that. So that right now it's still allowed, but it sounds like some hospitals, like even here in Chicago, like Children's Lurie's Hospital, has put a pause on that, even with that injunction that one judge has had for a temporary cease order for that. So, there was a protest even this weekend here in the Chicagoland area where people were protesting outside of Lurie's Children's Hospital saying, like, protesting why would they be canceling some of these surgeries, pausing this. So, yeah, there's definitely, I mean, you could even dissect the current administration's changes and orders and policies in 50 different ways. So, I'd have to think about what would make it a fruitful conversation, over the whole show. But yeah, if you have any more specifics, Pete, of maybe one specific area, I even thought about, should we talk about, I think right now it's a little premature. I'd like to see some of RFK's agendas more specifically, but I'm sure that would be a hot topic. I'd love to kind of see. I mean, again, some of that will not be up my alley because not all of what RFK does is going to be mental health related. But I've seen enough buzzwords, from RFK. I mean, for mental health, I think there's a couple things that maybe I agree with, don't agree. You've already heard my view on the overuse of stimulants in America. So when I hear RFK saying things like, we have too many Americans on stimulants, why is every kid on stimulants? I agree. I don't care what anyone says. Maybe that's a wrong attitude, but critics will criticize me all they want. But I swear, guys, it's not that it's coming. The stimulant epidemic is here. So there are things like that. I might agree with him. There's some things he says that I think are just crazy, and I do get a little concerned. I don't know that he's qualified for certain things to be making random comments with conspiracy theories. So I don't even know what to make. There are some things that I agree with him, some things where I'm just like, good Lord. what has America gotten themselves into? So I really try to look at it from a balanced point of view, because I mean, I think there are some things I might agree with to some degree, and others where I'm just shaking my head. So it would be interesting. So I'd actually even like to wait a little bit and see what else kind of comes out from him and Trump and whatever of the other appointees kind of talk about. But yeah, we could definitely do that, Pete. So I'll see what other concrete things kind of come out from these executive changes, but definitely that'll be on the to-do list. So psychopathy, sociopathy we'll put on the to-do list. RFK, government initiatives. Here's another one. Would you like to hear about cults? I don't know why. I've been interested on that topic, and I did, go to seminars in the past. I was just trying to understand the mindset of joining a cult. And I have talked to several former cult members about their rationale of why, what kind of lured them into that. But I know that's a very niche topic, but if you guys ever want to hear an episode on that, I could probably whip together some material for that. But that's always been an intriguing one. I don't know about you guys, but goddamn, when I was in undergrad, now I'm dating myself. I'm about to turn 43, but when I was an undergrad, good Lord, I underappreciated KG. That would be difficult. KG, I swear to God, KG, you think I'm being facetious? You and me, KG, we got to figure out a business deal on the side. We got to come up with some merch. Like, I know that would be offensive, but it's like that cynical edginess. I mean, we could make cult mugs, right? And make some cartoon caricature with difficult, right? It's difficult to leave, right? Whatever. I mean, like, we got it. You are so good at this. You don't even need me, KG. Like, you can give me, I don't even know. You can give me a what? You can 75 you, 25. So we can do a 75-25 split. Just give me the 25 for leveraging the little exposure I have, right? Or maybe we can even do 80-20, whatever. But we gotta. You're so good at this stuff. I serious, man. I'm not. This is not just empty accolades. You're. See, that's what I mean. Cult 45 beer. We can make a mug that. See, look at the merch possibilities. Look at all these other mental health gurus on social media and YouTube. It'd be like, kindness and compassion. Except screw that. Come on. That's been done. That's been done to death. Put your custom color and your monogram next to the word, next to buzzwords. Forget that, KG. Let's be edgy, right? Cult 45 beer. Man, see? Like that's where it is, man. And we're going to offend people. I think it's okay. We should go back to offending people. It's okay to offend people. We shouldn't be malicious and evil. I think it's okay to offend people with appropriate humor, right? It's okay to offend people. We can disagree and still be adults. We can agree to disagree. That's what makes America beautiful. Cult 45 beer. But yeah, I got to write. I'm going to forget, man. I have, my mind is shot. So we got psychopathy, we got cults, got RFK and Trump. All right, guys. I appreciate you guys. Thank you for the brainstorming session. You guys are always good for brainstorming together. So, all right, for those of you who have stuck it out till, midnight Central, 1 a.m. Eastern, good Lord, go to bed soon. I'm going to try to go to sleep soon, but I just downed some coffee, but I guess coffee doesn't do much for me. So we're going to sleep in about 20 minutes. But you guys get some rest. Hope you guys are doing well. You guys, thank you for the catharsis, the good laughter, the jokes. I appreciate you guys. I really do, especially for you regular listeners. So to me, this is therapy. This is how I'm letting out some of my pent up work angst and misery and burnout. So I really do. I appreciate you guys. So thank you for joining again. I'll stay tuned. I'll try my best to put out the bookmarks of the live streams a little earlier, but Saturday, 10:30 Central, 11:30 Eastern. Have a good week, guys. Till next time. Take it easy, everybody.